And so when we say we provide complex medical management, but we never use the code designed to capture that complexity, there's a disconnect. This conversation really isn't about revenue. It's about representation, in my opinion. Coding this is in the language that the healthcare systems use to understand our clinical care. And it's the language that payers analyze, and the language that researchers study, and the language that policymakers ultimately rely on when making decisions about healthcare delivery. And so when clinicians undercode the complexity of the work they perform, two things happen. First, the data underestimates what clinicians actually do. And second, the policy decisions get made based on incomplete information. Hello and welcome to the Chris Wolfe Podcast on iCode Media. Today I want to talk about a code that has created a lot of controversy, a lot of headlines, and honestly, a lot of confusion. And that code is G2211. Now, when CMS activated this code in 2024, the reaction across our profession was loud. Across medicine in general was loud. You know, some people celebrated it. We celebrated it at iCode. We celebrated it immediately. We actually put out a course in 2023, which I'll talk about later. And a lot of people criticized it, and a lot of people were afraid of it. And frankly, many of us just ignored it. But now we have finally something that we didn't have before, which is real data about the utilization of this code from the first year, from just 2024. Even though we have now 2 years of data, it's only been analyzed for one across Medicare. And it's actually pretty surprising. And so that's what we're going to talk about on today's monologue. Please, as always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. A question that I hear all the time is, should I be taking an AREDS 2 vitamin? With MacuHealth Plus, we can finally have a formulation that follows science without adding unnecessary ingredients, and we can rely on it to know what is in the container is actually what is labeled on the container. We use it specifically for intermediate AMD patients, and the patients with AREDS 2 data, it's the strongest for. And the ability to include mesozeaxanthin allows us to support macular function, not just slow disease progression, although it's good at that. That's why it's become a go-to in our clinic. All right, so a recent report analyzing these medical claims and these Medicare-specific claims data found that clinicians billed nearly $400 million in G2211 payments during the first year. $400 million is a ton. It sounds enormous, but the part that caught me and caught many people off guard was that CMS actually expected much greater utilization than that. In fact, they projected that the code would be used far more frequently across the entire broad healthcare system. So despite all the controversy and despite the headlines and despite all of the debate, the reality is that the code actually was underutilized compared to what Medicare expected. And it tells us something important. The healthcare system is still figuring out how to use the code appropriately. All professions are often using this code or trying to figure out how to use the code appropriately. And before we talk about optometry specifically, I think it helps to step back and try to understand what this code actually represents. So as you've heard me talk about this time and time again, G2211 is an evaluation and management complexity code that is an add-on code. And it's there to recognize the additional cognitive work that happens when a clinician provides care within a longitudinal patient relationship. So in other words, it acknowledges something that we as clinicians already know really well, which is that healthcare is not just about an isolated visit. It's about the ongoing responsibility for a patient over a longitudinal period of time. And that's actually what we advocate for. So according to CMS guidance, G2211 captures visits where the practitioner is either the continuing focal point for all the patient's healthcare needs or is providing ongoing management of a single serious or complex condition. All medical professionals who can bill for office or outpatient evaluation and management visits can use this code when those criteria are met, regardless of specialty. So the complexity that the code captures is not necessarily about the diagnosis itself. Instead, remember, it reflects the cognitive load and professional responsibility that comes from managing a patient's care over time within an established clinical relationship. So one of the most common things we hear in optometry is something like, well, G2211 is really a primary care code. We're not primary care providers, so it probably doesn't apply to us. But the policy itself says something very different. Remember that CMS explicitly states that the code is not restricted by specialty. And so any clinician who can bill an office or outpatient evaluation and management visit can report G2211 when those criteria are met. This is what we call specialty neutral codes. This code was designed to recognize complexity regardless of whether that complexity occurs in a primary care practice or a specialty care practice or any other specialty within medicine. And when this analysis looked at the Medicare data, they found something I think is fascinating, although based on all the things that occurred at the time, not, in my opinion, really unexpected, but it was that specialists and surgical physicians were responsible for a large share of claims. In fact, specialists use the code nearly half the time in the first year of implementation. And some specialists actually build the code more frequently than primary care physicians. So the idea that this code belongs exclusively to primary care simply isn't supported by the policy or by early utilization of the data. So this brings us to an important question for optometry. As a profession, we frequently tell legislators, health systems, and policymakers that we're managing serious medical eye diseases. We talk about managing glaucoma, macular degeneration, diabetic retinopathy, ocular surface disease, neurologic ocular conditions. And we emphasize that optometrists are providing ongoing medical management for patients with complex conditions. And in many cases, that statement is absolutely true. In fact, I believe it's almost entirely true. But here's the paradox. If we're truly managing these patients in a longitudinal relationship, and if we're truly responsible for the ongoing care of these patients who have complex diseases, then the coding data should reflect that work, because G2211 exists specifically to recognize the complexity of that kind of ongoing relationship. And so when we say we provide complex medical management, but we never use the code designed to capture that complexity, there's a disconnect. Parents often ask whether a daily disposable lens can really slow myopia progression. Well, with MiSight One Day, the answer is yes. And that's why it's one of our most used options for our young myopes. Kids adapt quickly, comfort's excellent, and compliance stays high because it's a daily lens. In my practice, that reliability is what allows us to confidently build long-term myopia management plans for our patients. Check it out for yourself. MiSight One Day. If you're ready to stop feeling overwhelmed and start running a safer, more profitable practice, here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today. This conversation really isn't about revenue. It's about representation, in my opinion. Coding this is in the language that the healthcare systems use to understand our clinical care. And it's the language that payers analyze, and the language that researchers study, and the language that policymakers ultimately rely on when making decisions about healthcare delivery. And so when clinicians undercode the complexity of the work they perform, two things happen. First, the data underestimates what clinicians actually do. And second, the policy decisions get made based on incomplete information. And so this Medscape article and the data, the study that actually looked into this Medicare that the Medscape article was highlighting, if they looked at optometry, what would they see? Would they see that we're similar to ENT physicians, specialty physicians that provide a lot of complex management and have a primary focal point for patients with related conditions? And so if optometry is truly delivering longitudinal care for these complex ocular diseases, then the claims data should reflect that reality. Because when policymakers analyze healthcare utilization, they're not listening to speeches or reading press releases. They're analyzing data. Now, to be fair, part of the reason this code has been underutilized is that there's been a lot of confusion around it. As I said before, clinicians have had questions about when the code should be used, when it should not be used, how it interacts with the E&M visits, and what documentation needs to show. And I think these are reasonable questions, right? They're reasonable uncertainties. And for many clinicians, the safest response has simply been to avoid the code altogether. But that hesitation, and it's understandable, but there are 2 years of real-world data and real-world implementation that we can have a much clearer guidance about how that code fits into clinical practice. For clinicians who want to understand how to apply this code appropriately within comprehensive optometry care practices, we've developed a course called Practical Implementation of G2211 in Comprehensive Care. Our PPP Pro members have had access to this course since the end of 2023. And over the past 2 years, many of those practices have successfully integrated the code into their workflows and gained confidence in understanding when it appropriately applies. The goal is not to build the code indiscriminately. The goal is to be simple, right? Use the code when it actually reflects the care that you're providing. And for many patients, it is often highly utilized because they understand that the type of care they're providing for these patients does fall into that. But the first year of G2211 gives us something really valuable because it gave us data. And that data showed, and we have refined what we have built within that course and within our guidance from a PPP standpoint, that data showed us that CMS expected wide use of the code. In fact, we knew that at the time when we built the course back in 2023 in anticipation of the 2024 change, was that CMS expected, once full adoption of this code, that over 50% of 9.9 codes would have that G2211 code applied to it. They expected within the first year it would be in the 30%, something like 38%. But this data showed us that it was about 14%. And it showed us that specialists across medicine are already using it. And it showed us that many clinicians are still uncertain about when to apply it. So for us, for optometry, the question going forward is, I think, straightforward. If we believe that we're managing complex ocular disease and we believe that we're providing longitudinal care for serious conditions, then our coding should reflect that the type of practice that we say we are in is actually the type of practice that we are in. Because modern healthcare data drives policy, unfortunately or fortunately, and coding is the language that creates that data. And if you want to learn more about how to implement G2211 appropriately in your practice, PPP Pro members can access that course right now. And if you're not yet a member, you can join and gain access, or you can use that course as a one-off. I'll put the link in the show notes, along with the link to the Medscape article and data that they're analyzing. And you can gain access to that training immediately. Understanding that code and how to describe the work we do is an important part of advancing our profession and accurately representing the care we provide our patients. So I hope this was helpful. I'll see you next week.